A cardiac anesthesiologist. I'm going to talk about a case we had in the cath lab. What I'm going to do is talk about the case itself and how we diagnose tension pneumothorax, and specifically what is the failure rate of needle decompression, in addition to how to perform a finger thoracostomy. Our patient was a 79-year-old female. She had controlled end organ dysfunction of multiple comorbidities, none of them life-threatening at the time: depression, anxiety, GERD, hypertension, lipidemia, hypothyroid, and left upper extremity lymphedema from breast cancer. Why she presented to the Texas Heart Institute is she had D2 classification of aortic stenosis, which is low flow, low gradient. She had a poor LV, normal RV, but WHO class 2 pulmonary hypertension. Unique to her case is that she came into the hospital in a heart failure exacerbation in which she required both IV diuresis and left thoracentesis for a pleural effusion. She also at the time was found to have antibodies on the blood. They were later to be found to be anti-K antibodies, but there was no blood readily available, albeit she was not anemic at the time preoperatively for her TAVR procedure. Our plan was to undergo TAVR with sedation. We planned to use a native airway, a right radial arterial line, and a right IJ central line for the interventionalist. This is the preoperative chest x-ray that occurred 2 days before. As you can see, we have bilateral pleural effusions. These are outlined in red, in addition to some atelectasis. This is the chest x-ray 1 day prior to the procedure. On the right side of the screen in the left lung field, you can see that this is improved from the left, as they had a moderate pleural effusion that needed to be drained. However, on the left field of the screen, which is the right chest, you can still see that they had some component of pleural effusion, pulmonary edema, and atelectasis present, likely from exacerbation of her heart failure. We brought her into the room, and she had really pinpoint arterial lines. Multiple attempts by myself were being underway. We went into the room about 3:45. In an effort for efficiency, and given it was later in the day, Dr. Dworkanath and I chose to tag team the line. So while I was working on the arterial line, Dr. Dworkanath attempted a surface approach right IJ central line with a micropuncture kit. And after the line was placed, it was noted that yellow pleural fluid was was aspirated from the line. His second attempt in the effort to need a definitive line for therapy was also surface approach, and this was uncomplicated aspiration of dark heme. Approximately 9 minutes later, the intrapleural catheter was removed and pressure was applied to the intrapleural line. About 2 minutes after this was removed, hypotension ensued, in which we tried bolusing with norepinephrine, epinephrine, and phenylephrine, but these were all unsuccessful. Approximately 4 minutes later, we noted that the patient was developing hypoxia in addition to hypotension. We grabbed an ultrasound and found that there was no lung sliding at the second intercostal level. At lung point revealed we had a pneumothorax. We didn't have any lung sliding there as well. And in the hybrid OR suite in Cath Lab 7, we obtained live fluoroscopy, which demonstrated a right pneumothorax. The patient was now developing obstructive shock, tension physiology from this pneumothorax. Approximately 30 seconds to 1 minute later, needle decompression was done by myself at the right mid-clavicular line in the second intercostal space. There was a whoosh of air in addition to improvement of our hemodynamics, which included a brief alleviation of blood pressure. It was then noted that we had worsening of hemodynamics, no improvement in the hypoxia, and so a second needle decompression was performed in the right mid-axillary line in the fourth intercostal space. I believe that this approach was an anterior mid-axillary approach. and air was also heard and an improvement in our hemodynamics. However, 1 minute later, we noted that the patient then developed refractory hypotension and hypoxia. She became ashen gray and endorsed impending doom. And so a right mid-axillary finger thoracostomy was performed by myself. There were no chest tubes readily available, but the chest was successfully vented. Pleural fluid was noted, approximately 500 cc's, and air was evacuated. The hemodynamics now improved, and the patient was now responsive to vasoactives. Our hypoxia improved from the 50s to the low 90s. Approximately a few minutes after this, we induced the patient and intubated the patient, converting to a general anesthetic. Approximately 25 minutes later, there was a delay in obtaining a CV surgeon immediately readily available to the room. The site was exchanged from a finger thoracostomy to a right-sided chest tube in which the site was unchanged. We then placed a transesophageal echo and noted that the patient had worsening RV dysfunction. Given that we knew that she had chronic LV dysfunction, we now had a change in our preoperative echo. The decision was then to abort the procedure, given her hemodynamic instability, and convert to a balloon pump. We decided to bring the patient to the ICU, and after dropping off to the ICU approximately 45 minutes later, the patient had hypovolemic shock and ongoing hemorrhagic blood loss. However, no blood was readily available. Approximately 2 hours after dropping the patient off, the patient returned to the operating room for right mediastinal exploration. This was the chest x-ray that was obtained prior to going to the operating room, and what we see is a right hemothorax. There was high volume output from the chest tube output, and the patient was anemic. Starting hemoglobin, as discussed, was 13, and it dropped to 7. We also had hemodynamic instability at this time. The anesthetic plan was a general anesthetic. However, in this particular instance, a bronchial blocker was placed, and the decision to resuscitate and use blood was also there. It was found that the patient had a right subclavian artery injury. It's unclear at this time whether this was as a direct result of the central line placement or the midclavicular needle decompression. Either way, the patient sustained a right subclavian artery injury that had to be repaired. She developed a prolonged hospital course and spent almost 2 months in the hospital prior to being discharged to hospice, but after her stabilization from her 2 procedures on the 9th, a 10-day course ensued in the ICU, and the patient was found to have an ischemic leg, was improving, came back to the ICU. 3 days later was emergently intubated for respiratory failure, and eventually was kept intubated, and she underwent her TAVR at the end of the month. She unfortunately didn't rally, and an open trach and G-tube were placed in the middle of July, or middle of December, and she was transferred to inpatient hospice. The first take-home point I want to talk about is failure of needle decompression. Failure of needle decompression can occur for various reasons. The first can be that the chest wall is just simply too thick. That's one of the options. The second is that you may just have refractory evidence of needle decompression requiring a definitive chest tube. And so this is where finger thoracostomy and emergent chest tube placement should be in our wheelhouse and should be in our expertise level, although we don't utilize this skill often. The best evidence from this paper came out of the Mayo Clinic that showed that the 4th or 5th intercostal space in the anterior axillary line has the lowest predicted failure rate of decompression if you use a 5-centimeter angiocath catheter. Given patients and their obesity has grown over the past several years, it's not unreasonable to choose this space if you're trying to obtain a low failure rate. In our particular case, we utilized all of these, particularly I believe this was a mid-axillary point, so we had a 38% failure the first time, a 31%, and it's hard to tell if it failed because we improved, but we just didn't have a definitive way to vent the chest. What I want to talk about today is finger thoracostomy. It's a 5-minute discussion on the indications. So it should be performed after you have tried a needle decompression in which you have severe hypotension and hypoxia that's otherwise not explained. If you're thinking about decompressing the chest in this manner, ruling out main stem intubation, mucus plugging, if you are intubated, would be prudent. The diagnostic evaluation can be done with plain film and also ultrasound guidance. Ultrasound being lack of lung sliding and identification of lung point can rule in or rule out a pneumothorax. The anatomy of the procedure first encompasses an understanding of the triangle of safety. And this can be difficult to accomplish in the presence of an emergency with a patient who is both hypotensive and hypoxic, but this is a zone that you can remain in and be confident as you're performing this procedure when the patient is in extremis. So the first edge is the lateral border of the pectoralis major. The axilla is your superior border, and the edge of your latissimus dorsi, along with the fifth intercostal space being the inferior aspect. In reality, this can be difficult, right? You can see that this is the border of the axilla. This is probably the fifth intercostal space. This looks like it's in the fourth intercostal space as it aligns with the nipple, and we have the edge of the pec major and then the latissimus dorsi. The steps to doing this are very simple, and so it's key to remember this as you will revert to training in emergency. Identifying the fourth or fifth intercostal space, particularly in the anterior aspect of the mid-axillary line. If you have a Kelly clamp, it's helpful to blunt dissect through this. Notice that he is not grabbing the tip of this Kelly clamp to bluntly dissect to prevent it going further. But what you can do is feel a pop once you've passed the parietal pleura into the lung, into the actual pleural space itself. His finger goes into the chest, and this evacuates any type of fluid, pleural effusion, hemothorax, or pleural fluid or air. And then if you have one available, a one-way seal. But in this particular case, we didn't have that. We had to await a chest tube kit down from the CVOR in order to place a chest tube. Any questions?